This is work that's probably more focused on the collaboration aspect that Denny talked about in terms of our biostatistics department. This is work, the talk I'm giving today is titled Women Are Rarely Screened in Accordance with American Cancer Society Guidelines. Only 1 in 6 women at high risk for breast cancer get an MRI as an adjunct to mammography. And this was joint work between my mentor Deb and I and Dr. Laura Barkey, Ms. Mary Freibogel, Stacy Jackson over at Envision Sally Joe Breast Centers. So a little background about, I'm a biostatistician interested in comparing screening tests. So a little background about mammography and breast mammography and breast MRI. 8 randomized controlled trials have shown that mammography, screening mammography, reduces breast cancer mortality. 6 prospective non-randomized trials show that MRI has a higher sensitivity than mammography in women at an increased risk of breast cancer. So these results spurred the American Cancer Society to issue some guidelines in 2007 that suggested women be evaluated for their lifetime risk of breast cancer using a model that depends on family history, as well as women at an elevated lifetime risk of breast cancer be screened with MRI annually as an adjunct to mammography. There are other criteria in those guidelines in terms of known genetic risk, first relatives who have a genetic BRCA1 or 2 and other syndromes in their family history. So, as a biostatistician interested in comparing screening tests, we went and hit the beat for some data, and we wanted to find some information on whether or not screening with the recommended guidelines would be an improvement over routine mammography screening. And what we found were a lot of questions around implementation science rather than a direct comparison of the 2 methods. First of all, working with the clinicians at Envision Sally Joe, we realized it would be helpful to understand what percentage of women actually coming into a screening clinic are at elevated lifetime risk. How many of those women would complete their recommended MRI if it were recommended, and to get an idea of how long a woman took to complete the recommended MRI. And we designed a retrospective observational study using their data. So the study included about 65,000 women, 35 years or older. They were presenting at Envision Sally Joe Breast Centers for routine mammography screening in any of the centers in the Denver metropolitan area. The data spanned between January 2008 to January 2009. And lifetime risk at that time was being assessed via the Gale model through the NCI website. Women who had a lifetime risk of 20% or greater received a recommendation for their screening MRI in the mammography report that was sent to their primary care physician. So that was their method of implementing the recommendation at the time. Women with elevated risk were followed for a year after their risk assessment to see if the a screening MRI was completed at Envision Sally Joe. And these are some results that we found. So about 2%, 1.9% of the 64,000 women Envision Sally Joe were identified as being at elevated lifetime risk based on the Gale model. How does that compare to other risk assessment methods? There was a study at the Avon Breast Center in Massachusetts General where the BRCA model was used to assess lifetime risk, and only about 0.5% of women there were identified as elevated lifetime risk via that MIST model. Those proportions are different. So the method you use to assess lifetime risk could have some difference in the implication in the screening clinics. How many women completed their MRIs? The women who received a recommendation for MRI, only about 15% had a record of completing the MRI within 1 year, so 1 in 6. So a lot of women who get the recommendation aren't necessarily completing the recommendation, which was what we were assuming everyone would get the recommendation, everyone would complete the recommendation, we could compare whether recommendations worked or did not, and the reality is, implementation science, that a lot of women weren't completing the recommendation. Did age affect their completion of recommended MRI? No, women under 40 years of age were 3 times more likely to to receive a recommendation for MRI than women 40 years or older. This is probably likely because women who are presenting for their routine screening at a younger age are aware of breast cancer risk in their family and more likely to be assessed as elevated lifetime risk. There was no difference in the age did not affect whether or not a woman completed the screening MRI. The time to suggested MRI, about 47% of the women, so we're talking about how long it takes women to complete the recommended screening MRI. So these 15% of women who completed the screening MRI, 60% of them completed the recommendation within the first 2 months of the recommendation being received. About 3/4 of them, 72%, completed it within the 6 months out from receiving the recommendation. And I'm going to make it. So there are some potential limitations to our study. The study does not, it relaxed some generalizability. This is one large-scale screening clinic in the Denver metropolitan area. Our study used one specific risk assessment model, and it did not account for loss to follow-up. That is whether or not women completed the screening MRI at other clinics. It's highly unlikely, though possible. So our big question that we started out wanting to answer before we addressed these questions is the implementation of the recommendation was, will screening according to the American Cancer Society guidelines lead to the detection of more cancers? So here's an example of a contrast-enhanced breast MRI. This is of the left breast, the cranial caudal view. And this is of a woman who came into Envision Sally Jobe, 45 years of age, was risk assessed, and she was classified as having elevated lifetime risk of breast cancer. She was screened with a contrast-enhanced screening MRI in conjunction with her screening mammogram. So the image on the right is the cranial caudal view of the left breast. And the lesion you see on the left is fairly apparent via the MRI, and the mammogram on the right, there is no visible lesion. Even the radiologist at the center said there's no real visible lesion of possible cancer. And this lesion on the left that was caught early was later biopsied and confirmed to be ductal carcinoma in situ. So this is the example of where MRI catches the cancer where mammography does not. So that's the benefit of MRI, but also we're hoping to address and answer more questions about the costs of this additional screening, including how many more false positives, what are the medical and monetary costs, and a whole host of other implementation questions. For example, what is the best way for a clinic to implement the screening guidelines, what risk models, how the information is translated, and what is the best way to educate women so that they are making informed decisions about whether or not they want to choose to receive screening MRI. So these are a lot of the implementation questions that we're hoping to address. We have based just recently 2 approved studies to look at more data from Envision Sally Jobe and hopefully address these questions. So that's a case study of a collaborating biostatistician. Thank you very much. Yeah.
Questions. We have time for questions.
Yes. So what happened in terms of risk assessment was a technologist would come in. A woman would go to a staging room. A technologist, I think is a proper term, would fill out the information and fill out the NCI Gale model, or fill out the information on paper, translate the paper to the NCI website where the Gale model is readily available, and then transcribe that into the medical record system of the clinic. So that was how risk assessment occurred. Well, so for this study, women were informed via the mammography report that was sent to their primary care physician. So the risk score that was collected at the clinic, the technologist collected information, calculated the risk score, translated it to their medical record. Their medical record was used to generate the mammography report with the radiologist recommendations that was later sent to their primary care physician. So that was what was implemented at this time. And so, as you know, there's a lot of questions about how to implement this recommendation. So some things have changed. They've moved to actually informing women personally via a letter that's generated and sent to the woman rather than the primary care physician. So the results of the since then, they moved, I think this is between 2009 and 2010, and one of the questions we want to address is whether or not this letter actually changed behavior, changed rates that were as far as women complying. So then the woman was personally informed about their screening risk and the recommended screening guidelines. So, I mean, yeah. Does that answer your question about how risk was assessed and how they were informed at this time and how they're being informed now? And it's an evolving process. Like, these recommendations are new, and researchers are learning how to implement them best to see whether or not they improve outcomes.
Yeah. Along that same line, in terms of the implementation and what happened with this particular program, so was there any follow-up beyond the initial connection between the primary care doc and the patient about this to encourage them to go get their mammogram? Was there any interim in that year?
So during this time, on this period, no. It was more of the process they wanted to put in place. It was, we know they should do this, let's put it in their report and send it to their clinician. One of the studies, in fact, is how do you craft or develop a moderator or a navigator or somebody to actually follow up, inform, and make sure this information is clearly communicated. And so we're in the process of implementing that and evaluating that for its efficacy.
Other questions?